Morning, everybody. Just waiting for our presenters to arrive. Morning, everybody. Thank you for joining us today. This is a follow-up to the FASD webinar that we ran, I think it was back in November, which everybody really enjoyed. It was really, really informative. We had some fantastic guest speakers. So we decided to schedule another one just to start sharing that kind of best practice and knowledge that's out there. So we decided to do a spotlight on Hull because they've done some quite targeted work. They've also been working with South Yorkshire. So we've got a few interesting presentations to share with you today. Jason's going to go through a bit of the data and the background to it all. And then Jason and Charlotte are going to talk through a collaborative project between Hull and South Yorkshire, where they developed a leaflet. Jason's then going to go on to go through an e-learning course that they developed in Hull with their learning and development team. And then we've got Kirsty Tunnicliffe from OHID, who's going to run through a literature review. So I'm going to hand over to Jason. Sorry, my name's Katie Connolly. I'm the Communications and Marketing Manager in the Centre for Excellence. We're an ICB team and we look at modifiable risk factors, so tobacco, alcohol, obesity. So we're just supporting and facilitating this work stream. So I'm going to hand over to Jason now.
Thanks, Katie. Morning, everyone. I'm just going to sort the slideshow out. Hopefully, I'm not very good at technology, but you just bear with me. Brilliant. Can you see that, Katie? That's fantastic. Right, welcome everyone. Yeah, I'm Jason Goforth, Public Health Lead for Children, Young People and Families for Hull City Council. Yeah, so this whole presentation is going to focus on some prevention work that we've done. So we've carried out a few interventions. We're going to look at some of that today. I'm going to talk a little bit about some of the data. Some of it's national data as well, because as we know that, getting local data is quite hard. So I'm going to talk about that. I've got some links to where we got the data from as well, so it might be quite useful if people want to go and read a bit more into it. Then I'm going to hand over to Kirsty, who's going to talk about the literature review. So I thought that'd be quite nice to do that first. That was a piece of work that we did as part of our Children and Young People COI, so across the region for public health teams, and it gives some recommendations. So that helps us sort of leads on nicely to the work that we're doing locally, so it sort of shapes that in terms of evidence. Then Charlotte's going to chat about some work that we've done with South Yorkshire, so development of leaflet and a short video as well. So that's quite a good piece to chat through. And then we'll go on to the local stuff that we've done. So chat about an e-learning package that we're developing currently, and that supports a full day course that practitioners can access currently, but we wanted something that was a bit shorter, so if people don't have a full day to commit to, they can do a short video. So that's what we're developing. I'll talk through the content of that, and then we'll go on to the last piece, which is a toolkit that we're developing for midwifery practitioners and health visitors to use out in practice. So looking at the screening that they'll do, and the pathway that we've got locally as well. And then I've put some time in the end for questions. Hopefully we'll have time. If not, please put them in the comments and we can always respond to them if we don't get time at the end. Brilliant. Hope you enjoy it. So we've gone through that. So I thought it'd be quite good just to do a bit of a spotlight on Hull. Some of you might already know this, so apologies if you do. But it's always good just to create a bit of a picture of the setup in Hull. So population just over 270,000. Lots of deprivation in Hull. Both most deprived local authority in England. Half our LSOA, so that's lower super output areas. If you don't know what LSOAs are, a bit similar to our wards locally, but it's something that we use nationally in terms of deprivation. Half of our LSOA areas in Hull are amongst the 5th nationally, so lots of deprivation locally and lots of need. What I've included some data around the national needs assessment that was carried out by Public Health England. I put the link in at the end as well, so if people want to go and read into this much more, if you haven't seen it already, it's quite a good read. Lots of risk factors in there, provides some data on drinking habits and alcohol in pregnancy, so it's quite a useful document to read as well. So I thought it'd be quite good to include some of that data that was included in there. So in terms of FASD, it requires alcohol exposure during pregnancy to occur. We don't have up-to-date data currently on alcohol exposed pregnancies, but we do have data on alcohol drinking habits across the population, and that's collected through the Health Survey for England. The most recent one was 2019, and that data showed that 22% of women in England did not drink alcohol in the last 12 months. 59% of women in England drank at levels within the UK CMO's low risk drinking guidelines, that is up to 14 units or less in the last week. 9% drank at an increasing risk level, so that's 14 to 35 units. 2% drank at a high risk level, that was over 35 units. And the figures for women drinking alcohol for more than 14 units per week varied across age groups, with the age 55 to 64 the most common, and that accounted to 20%. Some more data that included in that needs assessment estimate that alcohol consumption during pregnancy in different countries around the world placed the UK at the 4th highest, with 41% drinking during pregnancy. The study doesn't recognise significant limitations, however, so rely on people's memory to record alcohol use, and there could be inconsistent data on drinking patterns as well. A UK cohort study suggested this could be much higher, saying around 79% drinking in the first trimester and declining thereafter. I thought it's quite useful to put some data in from another piece of work as well. Again, I've put the link in at the end that showed there are a significant amount of pregnancies that are unplanned as well. So I thought it's quite useful to put that in, that if people are drinking and they don't know they're pregnant, then obviously there's a risk there as well. So this is why we're doing some of this prevention work, because of some of this data that we've got. The best data in terms of that needs assessment was from an infant feeding survey in 2010. So that data showed that 2 in 5 mothers, around 40%, drank alcohol during pregnancy, which was fewer than 2005, so it has gone down slightly. Mothers aged over 35 accounted for 52%. Mothers from managerial and professional occupations accounted for 51%, and mothers from white ethnic backgrounds accounted for 6%, were more likely to drink during pregnancy. Mothers in England and Wales were more likely to drink during pregnancy than mothers in Scotland and Northern Ireland. Again, that's taken from the needs assessment, so there's some really rich data in there. This was quite useful as well. So this map shows that the percentage of the population are aware of the alcohol recommendation during pregnancy. So this is the number of people that understand that drinking alcohol during pregnancy has lots of risks. And as you can see, Hull is around mid-70s, high 70%. So although it's not the worst, there is still work to do. Again, that's taken from the needs assessment, so it's quite a good resource. There's lots of information in there. And I think some of this comes from previously, the recommendations currently are that, the CMO recommends that we don't drink alcohol during pregnancy because there's no safe limit. But previously the messages might be a small amount is okay. So there's been mixed messages over time, and I think that's probably where, why we're seeing such a diverse understanding of alcohol recommendations during pregnancy. So there's still work to do, which has prompted some of this, prevention work that we're going to discuss today. That's a brief overview of some of the data. I'm just going to hand over to Kirsty now, who's going to chat through a literature review that she did for our sort of COI, community of interest group for public health, and this forms recommendations on sort of screening and other things that it has directed some of our work locally. I'm hoping you're here, Kirsty.
I am, yeah.
Brilliant. Do you want just tell me to go through when you're ready for me to change slide, and I can scoot through as you talk, if that's all right.
Yeah, absolutely fine, Jason. Yeah. Hi, everyone. As Katie and Jason have said, I work for the Office for Health Improvement and Disparities, which is part of the Department of Health. And I work in the Yorkshire and Humber team covering cross-risk factors. So I cover tobacco, alcohol and healthy weight. As Jason said, I undertook a literature review with colleagues in our local knowledge and intelligence service, and then just here to present the findings of that. So I think you can probably skip the next couple of slides, Jason. Yeah, brilliant. So we asked for 4 questions to be looked into as part of the literature review. So they're on screen, as you can see. So we were mainly focused on identifying how effective screening for substance misuse was. So it was a wide definition of substance misuse. So it wasn't just alcohol, it also included other substances. And we were particularly interested in what the risk or associated harm was on both the parents and also the children, so the family unit as a whole. We were also interested in looking into the acceptability and feasibility of screening, particularly amongst health visitors and midwives, and how that then impacted on families and whether practice changed depending on, you know, the screening tool that was used, and what was the most effective tool that could be used to screen for substance misuse. So that review was conducted back in November last year, and it returned a total of 156 results. So I did a bit of work to try and narrow that down to highlight the most relevant studies, but there are links included as part of the presentation to the full results if anyone's inclined to go through them. So I'm just going to present the results split per question. So we'll look at screening effectiveness first. So if you wouldn't mind moving on, Jason, that'd be great. Fabulous, thank you. So the main finding from all the evidence that was returned was that antenatal screening is effective, and that midwifery is really well placed to conduct that screening. The benefits were highest when the screening happened at the first antenatal appointment, and there was some evidence that called for screening at every antenatal appointment to increase the effectiveness, but there was recognition that this wasn't always practical and wasn't necessarily commonplace. Some of the evidence did discuss the benefits of screening everyone to eliminate the stigma that's associated still, I suppose, with particularly with alcohol use and being labelled as sort of an at-risk patient. So there was calls and discussion around the benefits, I suppose, and the consequences of universal screening. And the evidence was pretty kind of conclusive, I suppose, on ensuring that training was included as part of the pathway in the process, particularly around paediatric residency programmes. And then you can see on the slide there's some elements there for recommendations around what makes screening effective. So the continuity of care, making sure that's individualised and flexible, that communication is person-centred and non-judgmental, irrespective of screening practices and tools used, and making sure that the kind of honest and conversational approach is fundamental, really, to build that trust and increase confidence, I suppose, in both practitioner and patient as well. Particularly related to FASD, one of the papers looked specifically at FASD, and they saw an increase in the identification of hazardous alcohol use through lowering screening thresholds, alongside providing that tailored support and training. In this case, it was to midwives. And then another paper looked at, did a narrative review, and they looked at the different screening tools that could prevent new FASD cases and improve maternal and child health, which I'll pick up in a few slides when we look at the tools. Okay, we can move on to the next one, Jason. Thank you. So there was lots of themes around feasibility and acceptability, which you can see on the screen. So I'll just cover a few of them. So the key themes that were identified were about the perceived effectiveness of screening, alongside competing priorities, so how to manage the barriers, such as the time it takes, fitting it into an already big workload, whether the organisation supports that practice, and whether there's a clear protocol in place. There was also a theme around lack of skills or perceived lack of skills in terms of ability of practitioners to screen, especially in terms of what happens if there is a positive screen, where to signpost people to, or what the pathways would be. There was also, again, around sort of a lack of rapport or perceived difficulty building that rapport with a patient, given that appointments are quite short, and there was acknowledgement about the difficulties in building that trust and having those honest and open conversations in such a short space of time. There was an element of uncertainty and mistrust in evidence, and kind of links to what Jason was just saying about the perception of acceptable alcohol use during a pregnancy. I think there's still misconceptions. Certainly the research was mixed in terms of people's confidence and capability in the CMO's guidelines and the guidance. And there was some sustained belief that a small level of alcohol use during pregnancy is still safe, bearing in mind that these studies are not just UK specific, so I have to take that into consideration. But I thought that was an interesting finding to come out of this piece of this literature review. A couple of other themes. So one's around infrastructure. So for example, the management information systems not actually supporting screening. So practitioner may undertake the screening, but then if the infrastructure organisation or support's not there, then it creates additional barriers. And then there was also something around healthcare provider perceptions impacting on who they screen. So whether they think it would be effective. Potentially some of the research looked into practitioners' own relationship with alcohol and or substances impacting screening practices, and where bias came in there. So lots of different themes around sort of the acceptability, the feasibility. I think this is continued onto the next slide as well, Jason, if you wouldn't mind moving it on. Thank you. Yeah, so lots came out of this. Again, I'll just try and summarise it because there's loads of information here. But some of the key further points were about a call for a woman-centred philosophy of care. So looking at an evidence-based, tailored approach that focused particularly on capacity building in midwifery and nursing teams, and ultimately to build that confidence in screening capability. That was some of the key things to come out there. There was a big discussion in a couple of the papers about mandatory screening, whether that would be ultimately beneficial or would create additional barriers. There's potential for stigma and judgment to be reduced with that approach, but then there was also identified a potential lack of follow-up in childcare services and concerns about unintended consequences associated with mandatory screening. So I think the jury's still out on whether that's the right approach to take. There was also, as I mentioned previously, something around the consequences of a positive screen. So either lack of confidence or a lack of team or pathway to enable practitioners to have that confidence and capability to know what happens if there is a positive screen. Some of it was perceived, not actual. So there's that interplay that comes out amongst the review. And there's a call for consistency and standardisation across several areas, which you can see in the final kind of section on the slide. But one of the particular kind of points for consistency was the consistent use of the same tool to eliminate the fact that each tool has different thresholds for referrals. So ensuring that consistency across linked organisations or places within the pathway was really key. So just going to move on now to talk through the tools. So we asked the question of, is there one specific tool that would be best placed, particularly for health visitors as well as midwives? The short answer is no, not necessarily, but there were some tools that were kind of highlighted as gold standard, and that was per the NICE recommendation. So looking at audit first to establish then whether the brief intervention is required and what sort of signposting or referral would be necessary after that. There was some recommendation around certain tools could be used if time is limited, so taking into account of the barriers that were identified, there are some options there. But the main thing was that the screening tool should be appropriate to the setting it's being used in. Recommendations covered 3 levels of screening, and that sort of section comes from that paper that I mentioned previously, specifically looking at FASD, that there were kind of those tiers to screening. So you kind of routine screening using a specific tool, and then the kind of ultimate is laboratory-based screening. And obviously it depends on what's practical and realistic, I suppose, on the setting. The evidence did find that a universal programme of alcohol brief intervention in primary care would be cost effective. I thought that was quite an interesting finding, and there were lots of recommendations about including the use of making every contact count approaches and brief intervention for all healthcare professionals in a position to provide that education and support. The evidence also highlighted the importance of making sure there's a kind of a confidential or it's an anonymous setting, whether that's perceived or actual, to remove some of that pressure and stigma to provide those socially acceptable answers. And the evidence was clear that roles and responsibilities relating to screening and interventions need to be very clearly defined. So I've linked some of the recommended tools from the papers on the slide there. Particularly the if you've got high workload, not much time, those are the recommended tools there. And then finally, I just want to cover the final slide, which is gaps and opportunities. So it's worth recognising that there were some gaps in the literature. Although it was very thorough, there's always going to be some stuff that's not quite covered in the detail, I suppose, that we ideally want. So one of the big gaps was the patient perspective. So what patients are looking for in their providers, examining that nuance of relationship. There was some discussion about screening for tobacco use was accepted, and there was a perception that they would also be screened for alcohol use, but that didn't necessarily happen in practice. So kind of mismatch there in terms of expectations in some of the research. It could also have included kind of service user engagement and feedback. Again, that was lacking. It was mainly looking at, a lot of the papers looked at interviewing professionals and practitioners and not necessarily covering in detail the patient feedback and the patient pathway. There were limited UK-based studies, so there was a very high proportion of American studies included. Some from Australia, some from Canada, and then we had a few papers from Sweden, Norway and South Africa. So there was a range, but predominantly high income countries as well were kind of overrepresented. And the other thing to say is that from a practitioner point of view, even though we asked specifically for health visitor specific papers, there was just a lack of evidence for that. So it's predominantly focused on midwives. So I'd say they were also overrepresented. And then just a few examples tried to pull out for opportunities. So areas for innovation included the use of tech, mobile intervention. There was an example that used a mocktail recipe booklet that was very effective. There was talk of pre-pregnancy initiatives and looking at an electronic screening tool for brief intervention for home visiting, but that's not actually been tested in terms of the feasibility of effectiveness. It was a proposal for an idea. And I think that's me, Jason. I think that's all of the parts.
Brilliant. Thank you very much, Kirsty. I think it's just important to say that you know, a lot of this, the cases covered is informed some of the work that we're doing locally as well. So really valuable research and feedback, and it's shaped some of the work that we're carrying out locally as well. So fantastic. Thank you, Kirsty, for delivering that. I think the next, so this brings us nicely on to, I'll just skip through those slides. The work we're doing locally. Just before I hand over to Charlotte, so what we did, we were successful in gaining a short grant from our ICB. They had an inequalities fund, and that's what we use the funding for, to focus on prevention, and that's where this work is stemmed from. So we're quite successful in getting a small amount, and that allowed us to do this work. And then I'll talk through our interventions. But we've got Charlotte, who's just going to chat about the joint work we did with South Yorkshire. Is Charlotte about?
Yeah, Mummy, yeah.
Yep. Are you okay to chat through the next couple of slides, Charlotte? Is that okay? Just want to introduce yourself. Is that all right?
Yeah, of course. Hi, everyone. I'm Charlotte Thornton. I work for the regional team at NHS England. So we cover North Eastern Yorkshire, and I work in the physical health and prevention team on alcohol prevention. So this is just a brief update about a couple of projects. I'm a lot closer to the filming project than I'm the leaflet. So if I can't answer any questions today, I'm more than happy to take them away. If you could do next slide, please, Jason. Hopefully there we are. So the first one, the opportunity arose because there was an underspend that was already paid to a provider by another one of our prevention programmes where they couldn't develop this film. So we had an opportunity for a filming topic, and from previous conversations, it'd been identified that a very brief 4 to 6 minute video for any healthcare professional who wants to have a conversation around alcohol in pregnancy for either someone looking to conceive or currently pregnant, about current guidelines, how to have that conversation, how to try and reduce stigma, etc. So that's the premise of this project. So we've been working with contacts from across North Eastern Yorkshire to develop a script. We've had lots of people involved in this script development. And I have been advised that we will have an auto cue on the day of filming, so the script should be pretty much ready to go. The filming will take place in 2 locations because the funding gives us 2 days of filming. So the first one is going to take place in Hull on the 22nd of May at the Rainbow Family Hub, and the second one is going to take place on the 29th of May in Sheffield. We are still looking for volunteers, if anybody knows anybody, for B-roll images, which until I started this project, I didn't know what B-roll images were, but apparently they're the images that while the script plays in the background, you see a patient having a conversation with a healthcare professional, etc. So if anybody would like to play a part in the film, there is our email address on there, and you're more than welcome to. And then the film won't be branded as NHS England, it'll be branded with either LMNS or ICB logo on it, and it'll be disseminated for use once available. We're expecting it about June or July. As I mentioned, all the filming should have finished by the end of May, but obviously all projects are subject to delay, aren't they? So, but yeah, we should be expecting it June and July, and then it can be circulated wherever it would be appropriate for use. Next slide, please, Jason. So the other project that was mentioned is the leaflet for patients. So South Yorkshire are leading the development of the content for this. Again, they've gone out to everybody for feedback on the content that one of their LMNS leads first started. This one, rather than it being North Eastern Yorkshire, is Yorkshire and Humber, as it's those 3 ICB areas that have financially contributed to the development of the leaflet, and we are expecting the first initial draft any time now from the content creators for that. and then that'll be ready to be circulated for comment, etc. So hopefully that both projects will be ready soon and available for both patients and healthcare professionals.
Brilliant, thanks Charlotte, really appreciate that. Which now brings us on nicely onto the stuff we're doing in Hull. So as I mentioned at the start, we are in the process of developing an e-learning package. We do have a full day course available for professionals. So this is a shorter version and it's sort of a precursor to that. So the idea is, if you remember, Cassie was talking about sort of the MEC approach. So it's almost using the workforce as a resource. So we're equipping them with the tools, and when they're working with families, women before, during, or after pregnancy, they've got the knowledge to pass that on. So it's using them as a resource locally. The idea is that, you know, we've used some of the funding that we received to develop this. We've got our learning development putting it together as we speak, and once it's finished, we're happy to share this with partners as well if people think it would be useful. Around about 45 minutes in length. It's aimed at professionals, and yeah, we want to sort of skill them up to go out and have the tools to have those conversations. In terms of the content, so it's split into 5 sections. So the first one is looking at general alcohol harm and education. Then it'll go on to alcohol in pregnancy and FASD, and provide an awareness of that and an understanding. And then it looks at the guidance for alcohol in pregnancy. So the Chief Medical Officer's current guidance of, you know, recommending no alcohol during pregnancy is the safest way. And then there's a bit about delivering a brief intervention as well. So, you know, we will equip them with a sort of knowledge and information on delivering a brief intervention when they're working with people locally. And then there's a resource section as well. So if people want further information, they can sign up to that full day course, and there's lots of websites and resources as well that's including that if they want to go out and expand their knowledge further. So in terms of each section, when we look at section 1, so general alcohol harm and education, it looks at alcohol costs to society, the effects of alcohol on the body, explore the reasons why people drink alcohol, and then it looks at the units of alcohol as well. So it's quite interactive. We've got quizzes on there as well to test the knowledge, and there's resources on there as well. So there's like a unit graphic that people can use as well. So lots of interactive resources included. In terms of section 2, so when it looks at alcohol in pregnancy and FASD, it looks at statistics on drinking and pregnancy. What happens when somebody drinks alcohol during pregnancy, so sort of the physiologically approach and how it affects the body. Risks associated with alcohol during pregnancy, and then what is FASD and the general understanding of FASD as well. Section 3 looks at the guidelines on alcohol throughout pregnancy. So this is getting them to, you know, equipping them with the knowledge and the messages that we want them to pass on to members of the public when they're working with them, and supporting the prevention work when working with women and families. And then the brief intervention. So this one will, you know, explain what a brief intervention is, how to deliver a brief intervention, and how brief interventions can support reduce alcohol in pregnancy. So it's giving them the skills to go out there and support some of that preventative work. And then, as I said, the last section is looking at resources that are available. And if they want to expand the knowledge further, they can book onto that full day course that we have locally as well. In terms of the toolkit, so this is something that, again, following the sort of stuff Kirsty mentioned, the evidence and research that's out there, we wanted to sort of develop something that would provide consistency across visits and the workforce. So we're developing a toolkit locally. I've got to say that, you know, that it's really important. I think partnership is key to this. So we're working with our LM&S and local hospital trusts and maternity services to do this. You've got to do it in partnership, as well as services outside. So, you know, we've got our local drug and alcohol service who can provide training to support this. So things like your ODC screening, you know, the may need training around that. So it's developing a training package to support it. All our midwifery staff and health visitors have had difficult conversation training. That's something the LM&S delivered. Again, that might be something that you might have locally, so that, you know, people are confident and comfortable with having difficult conversations. So that's really, really important as well. So yeah, the toolkit, really, the aim of the toolkit is we're taking a universal approach. So women, you know, the idea is that women are asked about their alcohol use antenatally, and we'd like to, we want to use the Audit C tool. That's the preferred screening tool for us. It's easy to use, it's quick, it's, because as Casey mentioned, time is a, it's scarce for professionals who've got so much to cover, so making it as easy as possible is what we're trying at the aim of the toolkit. And again, it supports things like the MEC, the e-learning package that we mentioned. It's about advice on avoiding alcohol throughout pregnancy and getting that message out there to people. But also, if this, depending on the results of the Audit C, there will be pathways into specialist services and further support if needed as well. And then more importantly to mention as well, the results are recorded. That's really important, particularly if later down the line that the child may go on to have a FASD assessment diagnosis. The history of that is really important. So it's really important that the results are recorded on records. And as I said, it's about bringing a consistent approach across midwifery and health visiting. We would look to expand this to other parts of the system in the future, but initially it's just to get this off the ground, working with midwifery and health visiting services. And it's about providing a resource as well. So we would like this to be a resource that people can take out. So there's hard copies if they're working out in the community, but also we've got Badgernet locally. So some of this will go on to Badgernet and they can use it electronically in practice as well. But as I said, we want it to be as simple as possible. But I can't emphasise that the partnership approach is really key here. So working with the LMNS, your midwifery trust, to 19 providers, use drug and alcohol services. It's a real sort of joint approach to develop something like this, because it needs bits of each system to do it. So training from your specialists around drug and alcohol and passing that on to midwifery and health visitors, your midwifery service to get things on Badgernet and work with midwives and health visitors to develop the pathway and the toolkit as well. So it's really, really important that, if you are going to do this, if you haven't got it already, that that would be my advice, is to work in partnership with key people. I think we're on to questions. I've just put a slide on there as well about some of the resources. So there is the link to the FASD needs assessment that I mentioned in the first few slides, and looking at some data. It's a really good read. There's lots of information on there if you wanted to go a bit further and have a look at that. Lots of recommendations as well. It's a really good resource. There is the National FASD website as well. There's lots of resources on there for people. I think I'm right in saying that midwifery get the training free as well, so it's quite good to access. Others will have to pay a small amount, but there's lots of leaflets and resources on there. But do have a look if you haven't seen that. It's a really good place to again expand your knowledge and get further resources. And then the other things are just around alcohol and pregnancy in general. I've put the Dramester website on there as well, because I think that's a fantastic resource. So that's something Manchester developed. It's worth a look. That's something you can sort of buy into, and they can expand it and you can deliver it locally. So there's an option there, so you can get in touch with them if you think it's really good. Other areas have bought into that, and they use it locally, so as a campaign locally, but it's really, really good. Lots of resources on there for people to have a look at. We've finished a bit early, but I'm going to open it up for any questions.
I think there's been a couple in the chat, Jason, as well. Just had a comment from Marie Archibald saying that FAST is easier to use. The alcohol care team in Hull use FAST to screen, then go on to use Audit and SADQ, and they can also signpost to local support. So I don't know whether that's a sort of different way of looking at it, but something to consider. And then we also had a comment from Anna Brown asking, did the literature review consider the relevance of the usual alcohol screening tools in pregnancy where there is a different level of risk to be identified?
Yeah, I would say generally a couple of things about the review. So first of all, that the review itself wasn't specific to pregnancy. We kind of kept the questions a bit broader than that to, I guess, cast a wide net to try and capture as much of the research and evidence as possible. But there was a lot of discussion around different screening tools, and some of the papers looked specifically at screening during pregnancy, which I'm happy to highlight which papers they were. There was one in particular that was really, really useful in terms of the summary of the different tools, And it was that paper that recommended about lowering those screening thresholds to try and capture and identify the different levels of risk as well. So I'll see if I can somehow pop the paper in the chat. I'll work it out.
That'd be great, thank you. Then we just had a comment from Alison Ferguson saying, from a preventative perspective, having information in sexual health services would help to get messages understood. Yeah, I think that's a great idea. I suppose that can work hand in hand with that kind of system partnership.
Yeah. I think it's just exploring every opportunity. I mean, I'm involved in some sort of teenage pregnancy work, so there'll be so many opportunities out there. You're absolutely right. Get into wherever you can, and it's about getting those messages far and wide into it. And the more we do that, the more people understand it, and hopefully that graph that we saw at the start, that map of England, will get darker and more people will understand the recommendations. And I think the schools one, yeah, definitely. I mean, we do have. In Hull, we have our young people's drug and alcohol services going into schools, so I think we've got quite a strong offer there. But you're right, absolutely. Again, it's getting into all those areas, isn't it? And it's opportunistic. Yeah,
absolutely. Now, I don't know if anybody's got any further questions. No, I think you stunned them into silence, Jason.
I'm going to put my email address in the chat, and then if people are interested in any of the work, just drop me an email and we can share things. If people are developing something similar or just want to chat, I'm happy to meet up and or share what we've done locally as well, if that would be useful for people.
I think that's brilliant, Jason. I think there's a real appetite for people to sort of do more on FASD, and I think it speaks to it, the number of people that are here today as well. So I think any learning that we can share and different practices in different areas, it just saves reinventing the wheel, doesn't it, as kind of different areas explore this. So thank you very much for sharing with everybody. Brilliant. Thank you also to Kirsty and Charlotte for coming along today. Really, really helpful. And we will circulate all the slides afterwards. If everybody can send them over to me, I'll collate those and send them round to everybody that attended. I'm just going to have a quick look at the chat because there's a bit more going on in there. We've just got a question from Maria asking if the diagnostic pathways are available in Hull yet.
Not yet. I think that's ongoing, Maria. The stuff I've tried to do is around prevention, and there is absolutely that, that stuff needs developing the assessment diagnosis. That's another area that we need to focus on as well. But discussions are ongoing. We've got the group locally to try and develop that. There is going to be a meeting with our ICB colleagues to maybe look at how we progress some of that work. But I didn't want that to hold up the prevention stuff, so that's why I've carried on, because I think it's really important trying to prevent it as well. But yeah, fingers crossed we can get that moving and get some stuff developed.
Brilliant, thanks, Jason. Well, without further ado, we can give you 13 minutes of your morning back to go and get a nice cup of tea before your next meetings or whatever you're going on to next.